So it's a pleasure to introduce Shaine Morris. Shaine is a pediatric cardiologist from Houston with a strong interest in aortic disease. It's also a pleasure to introduce Shaine because we trained together at Boston Children's Hospital. So without further delay, Shaine.
Great. Thank you. And thank you so much for the opportunity to be here again. I was here, I was in Toronto last year, and this is really just a wonderful meeting and my opportunity to nerd out with other people who love the aorta. So there's not that many people in pediatrics, so thank you, everyone. One thing I'm just going to, I did not include part of my general soapbox in this talk because of the limited time just about the prior conversation, but I do think it's an amazing world we're in, being so multidisciplinary between genetics, basic science, translational work, cardiology, and surgery. But I think that does limit us in some senses, is that a lot of our aortic guidelines, we sort of take, well, who dissected, what's the lowest diameter, that's our cutoff. But that's not really the proper way to study aortic diameters. We have to look at people who did not dissect, and that's our diameter. And I think that really needs to, we need to take our clinical outcomes research methodologies and apply those to guidelines, because those of us that are cardiology and are the front lines, not quite the front lines as surgeons, but having to advocate for our patients whether they need surgery or not, we really need better data than, 1 in 1,000 patients dissected at 4 centimeters. So. Anyway, but I'm not going to talk about that today. We're going to, so a lot of people today have talked about aortic risk factors besides size. So I'm going to mention a lot of the ones that I've talked about. I'm going to focus on a couple that people haven't talked about too much and talk about tortuosity and a little bit about methodologies to model these patients in the future. So again, as a cardiologist, we are confronted with this all the time. We see people with various similar overlapping phenotypes. These are 4 patients, all with different genetic mutations, who have a variety of aortic pathology: ascending aortic dilation, aortic root dilation, abnormal aortic arches, presenting with dissections, and we have to decide what to do with them. And as everyone has mentioned today, size is a very poor predictor of what to do and to intervene. There is some correlation, but it is not predictive. So there's some challenges, though, when we're studying risk factors, when we're writing papers. So we know many factors affect risk. But first of all, what does risk mean? I think people mean different things when they say high risk. So you might mean, well, this patient has a high risk of having dilation, which we'll say in children, or an aneurysm. And that's what a lot of studies evaluate, because this is rare disease. Everyone has dilation, not everyone has dissection. So a lot of our studies, high risk is a more rapid dilation, but that doesn't always mean dissection. High risk might mean this population has a high risk of dissection. 20% of people with this disease will dissect before they die. 30% of people with this disease, but we then don't take into account, did they dissect at 4 centimeters, did they dissect at 7 centimeters? And what people are focusing on more, which I think is a little more well-articulated definition of risk, what's the risk of dissection at a small diameter at an early age? And it's really hard to get all of these different ideas in one outcome measure and to say, okay, well, I'm going to just look at you. What if you dissect at 5 centimeters, but you're 3? What if you dissect at 5 centimeters and you're 80? That's a really different group of patients. And again, we have to think about that as we're studying things. So any prediction algorithm will be multifactorial. And this is what we're all doing when we take a case into our head. We're saying, well, are they a female? Are they big? Are they small? What's the gene? What's the dilation? But how do we more sophisticatedly look at this? So these are the current risk factors that we've talked about today. So what gene is affected? Specific genetic variant or variant type, meaning that there are some more pathogenic or more aggressive variants within specific genes. Obviously sex, which is sort of dichotomous. Males are at higher risk, but females in some genes are at higher risk at smaller diameters. Family history, we've discussed a lot. BAV, which I'm going to mention in a minute. This is on top of other genetically mediated disease. Obviously age, it's not mentioned enough as a risk factor, but if I see a child with a Z-score of 10, they're not going to dissect. If you take that same CT and say this is a 19-year-old, they'll immediately go to surgery. So age is a huge risk factor. Obviously aortic dimensions, pregnancy, hypertension. Interventions, obviously they're getting a valve-sparing root replacement. Even if they have a type A dissection, a distal ascending dissection, they're not going to have the same risk as someone who has not had that. Medical therapy, in which we alter the rate of dilation, arterial tortuosity, which I'm going to talk about, and then some more novel predictors. Now, as you see, as I put this up here, I put this on static category and dynamic category. And this is now talking as a research scientist. When we have to study these risk factors, we have to think about how they change. A lot of studies say, well, do they have this or do they not have this? And that's really easy. Is this a male? Is this a female? Is this a TGFBR1 mutation or is this a TGFBR2 mutation? Well, that's fine. Those are static predictors. They're the same from the day you're born to the day you die. But it's much harder to study dynamic risk factors. Age, it's always changing. Pregnancy, you're sort of peripartum for a few months, you're pregnant for a few months. Aortic dimensions are constantly increasing. You might have hypertension when you're 35, but you didn't when you're 19. And it's a much more difficult thing to study, and I think because it's difficult, people often don't take dynamic factors into account other than size. If you look at a lot of Kaplan-Meier's, they're like, pregnant, not pregnant. Well, they're not pregnant for the 5 years you follow them. They were only pregnant for a short amount of time. They might have been hypertensive, but they might have been on effective therapy. It's really hard to study, and it's just something to wrap your head around as you're studying these patients. So one thing, I'm going to talk about a couple of things today just to focus on. One is when you have bicuspid valve in the presence of Marfan or Loeys-Dietz syndrome, what that means and how this is different than other conditions, and also about arterial tortuosity. I'm going to focus on those two because I think those haven't been highlighted that much today, and then a little about modeling, talking about everything. So again, this is a patient of ours, 13-year-old patient, referred to cardiology clinic with a history of aortic dilation. We talked about all the things we're going to take into account. But what about this patient? So this patient ended up having BAV, and I'm waiting for the genetics to come back. So does BAV modify, this person also had features of connective tissue disorder. Does it modify disease or increase risk when you have a connective tissue disorder? So we're not talking about BAV alone, all right? We're talking about a subphenotype if you have Marfan, Loeys-Dietz, some of the other syndromes. So this is a beautiful article done in Marfan syndrome looking at what if you have BAV on top of Marfan syndrome? And the hypothesis was that obviously it increases your risk. And if you look at these graphs, I don't know if this y-axis is a little hard to read. This is the diameter of the sinus of Valsalva. This is the diameter of this is the Z-score. And definitely the ones in red have BAV. This is on top of FBN1 positive Marfan syndrome. You can see that their aortas are bigger. Okay, no surprise, this is aortic root. Other points, so it occurred in 1.8%, 2/3 were male, not surprisingly. But at larger aorta, even when you controlled for the fact that males were larger, but no one in this group had an aortic dissection compared to a measurable proportion of the patients that had an aortic dissection with tricuspid aortic valve. And generally, they had surgery at a younger age. And what came out of this study in Marfan syndrome is that bicuspid valve is probably a totally separate, overlapping condition. Maybe it exhibits a little bit of extra risk, but because we're treating them like bicuspid valve, they're operating earlier, it doesn't modify their risk tremendously. You operate earlier, they're fine, they're controlled well. We'll compare that to our patients with Loeys-Dietz syndrome. So this is a longitudinal study of our patients with Loeys-Dietz syndrome who are young. These are all children. And if you look at this, each of the colors is a different genotype. So the ones in red have TGFBR2 mutations. The ones in green, TGF-beta2. The ones in blue are TGFBR1. These are similar graphs. This is aortic root diameter and aortic Z-score. These are slopes below. And if you look, you could just eyeball it. You can see that the TGFBR2 patients have a more rapid slope and generally are bigger. The ones with dots are the ones that went to aortic surgery. And what's interesting with BAV, all the stars are the ones with BAV. So our most severe patients all had BAV. And in this situation, these patients were more severe, more aggressive, but it did not seem like it's something on top of them that made them a bigger phenotype. These patients didn't have much larger ascending aortas, much worse valves. These were the worst patients. And I'd argue that in this population, when you see a BAV, and we see these patients little because they have a murmur, they have a bicuspid valve murmur, that this actually signifies a more severe phenotype of Loeys-Dietz. We know that in all these patients were TGFBR2. So we know that in TGFBR2, they have almost a 10% chance of having BAV. And I think it's a totally different story in this than in Marfan syndrome, that this is part of the more severe phenotype or of the higher risk stratification. And in this entire cohort, we've had 2 patients dissect, and they both were TGFBR2 with bicuspid valve, not dissected in childhood. So, interesting. Now, so what we learned from that is in Marfan syndrome, it probably mildly modifies the phenotype and is additive, but in Loeys-Dietz, at least in TGFBR2, it may be a sign of intrinsically more aggressive disease. All right, on to another risk factor, arterial tortuosity. So you guys might have seen this from our work a few years ago. This was a pilot study in children, and basically we noted that in TGFBR1 and TGFBR2 mutations, they have increased vertebral artery tortuosity. They've increased arterial tortuosity everywhere, but it seemed to be present. But we noted that a number of our patients with Marfan syndrome also had increased arterial tortuosity. And we said, well, is that measurable and is it associated with outcomes in our patients? So we developed this vertebral artery tortuosity index, which is a few other people have shown. It's very easily done from a CT or MRI. You just take the excess length over the straight length and take that. So if this was 15 centimeters and this was 10, it'd be 50% higher. And first we looked among our patients and said, who has elevated tortuosity? Normal is less than 10, average is 4%. And we saw that in our EDS 1 and 2, this is this sample cohort, Marfan syndrome and Loeys-Dietz all had increased tortuosity. And this, just to give an example, this was widely variable in families. So this is a patient with a TGFBR2 mutation who had a VTI, vertebral artery tortuosity index, of 190. This is a patient with Marfan syndrome, 45. Whoop. This is a patient with TGFBR2 mutation who had 43, and this is this patient's mother who had a VTI of only 8. So certainly we saw that arterial tortuosity is not only present in Loeys-Dietz syndrome, and in fact wasn't consistent in families. We saw it both in Marfan and Loeys-Dietz. And in fact, since that time, we've seen it in lots of other syndromes. You can actually see it in severe forms of Turner syndrome. TGF-beta2 has it. This is Marfan arterial tortuosity syndrome. This is just a graph looking at VTI among a bunch of different disorders. And here's our controls again, less than 10. Here's our call 3A1. This is a group we're investigating right now. Generally, they have very low tortuosity, but there are patients that have quite elevated tortuosity. And are these the higher risk patients? We can see it in Turner syndrome. And then, of course, we see it in the disorders we discussed, including MYHL11. Now, when we looked to see if this was associated with events, we saw that having a higher VTI was associated with increased risk for dissection or death, and this panned out in a multivariable analysis, while the diagnosis, TGFBR1, BR2, or Marfan syndrome, did not pan out. But the two biggest indicators were root Z-score and VTI. And why do we think this is happening? Well, the overall hypothesis, like just in general, is that there's abnormal lengthening in a fixed space. So as this vessel lengthens and it doesn't have anywhere to go, it folds on itself and bends. And the thought is that this is a maladaptation to stress, that it lengthens to sort of reduce the axial stress, or that the vessel is just totally genetically abnormal and has lower manifest axial tension. And that has been shown in some rabbit carotid arteries. There's also been some hypotheses that it's excess TGF-beta beta expression causing this. Now, all of those theories, when we thought about it, we said, well, how would tortuosity change with age? So we just took a one-time measure of tortuosity and said, is it associated with dissection or death? Yes. But is this a static factor or is it a dynamic factor? Does it change with age? Do we follow it? And then how do you use it in clinical care? If you say, oh, you're above 50, you're severe, but does that mean you're going to dissect soon? How do we use it? So we've done further work to try to characterize this. So then we looked at a bunch of our patients who had had at least 2 MRIs or 2 CTs, and we measured tortuosity the exact same age. Every patient had up to the brain, down to the arch. We measured it identically, and these are patients with TGFBR1, TGFBR2, and Marfan syndrome. And we were really surprised. So this is with the x-axis being age, and this is x-axis being height. Now our hypothesis was that tortuosity went up with age. Sort of as your vessels got more stress, as you had more hypertension, as you had more heartbeats, the vessel got damaged and it curled on itself. But what you see here, I'll orient you a little bit. This is the VTI. These are the patients with really severely elevated VTI, so it's a little harder to measure, a little harder to follow over time. But if you look at these lower patients, almost everyone decreases their tortuosity over time. And in fact, the best correlation is with height. And it turns out what's happening is you have your highest vertebral artery tortuosity at birth, and then you grow, and it stretches out. And probably after 50, our patients were under 50 that we included. This was only under 20 for this graph. Probably after 50, there are extrinsic issues, and you probably do increase your tortuosity, because there's autopsy studies that show that geriatric people have a lot of vertebral artery tortuosity. But in Marfan and Loeys-Dietz, as an indicator of severity, this is present at birth, which is very interesting. So then we said, well, can we reliably predict what it was at birth doing a one-time measurement? Is there a reliable correlation between height and tortuosity? And there is. It basically decreases by 1% per year. And so if you're on a more severe scale, it'll decrease more rapidly. If you're more mild, it will decrease more slowly. And it's 1% per year. So you can actually index, you can take a one-time tortuosity measure and say, what's your severity? The problem, not the problem, but the the thing to know about that is it then becomes a static risk factor. It's like BAV, or it's like genotype, or it's like gene affected. You say you're in the high risk group or you're in the low risk group. And so while that's really cool, you still then need a dynamic factor to follow, aortic dimension, something that's changing over time, because we're not going to operate on people when they're a day old, and we find this, right? You can, when you're a week old, you can say you have Marfan syndrome, you have a Z-score of 10, you have a tortuosity of 75, but you still need something else changing, another dynamic risk factor. So we looked at patients, we looked at our cohort of patients. Now this is a population we're studying right now that is about 300 patients from the GenTAC registry and 300 patients that we personally follow at Texas Children's Hospital, patients or adults. And we stratified using, this is VTI height indexed, and we stratified it by, we developed this from an ROC curve, height index greater than 68 or less than 68, and looked at specifically at type A aortic dissection with increasing age. And we saw that patients who had a high vertebral artery tortuosity were much more likely to dissect at an earlier age. But the question is then, oh sorry, here, I'll split this too. We also separated this into Marfan, into the Loeys-Dietz, and we see the same pattern. Now this one was not quite significant because it was a lower number of patients, but we see an identical pattern. And in fact, the people with low tortuosity have much lower risk. So we then wanted to create a multivariable model, and using all these time-dependent covariates, using age as it's changing, genotype, sex, BAV, pregnancy history, so people you could make them pregnant in the model for a while, then not pregnant, history of surgery, history of dissection, all these could change. So we looked at their childhood when these weren't present, their adulthood when they were. And we did this multivariable analysis. We had about 30 risk factors and came down to 3. VTI, height adjusted, persisted as a strong risk factor for type A aortic dissection, 2.89. Interestingly, patients who had a type B dissection as their first dissection and did not have a root replacement was strongly associated with a type A dissection in the following 2 years, and female and peripartum, and this was including pregnancy and the 3 months postpartum. And these came out in a multivariable analysis as our only 3 risk factors for type A dissection in our group. Now, this is a different way of looking at it. Then we said, well, regardless of what we say, people are still going to probably operate at 5, right? So who dissects less than 5? So this is an interesting nomogram or diagram. Across the x-axis is not age. This is now root dimension. So if you look at it, you say, okay, what percent of patients dissected at 4 centimeters? What percent dissected at 5 centimeters? 5, 5. 6, 7. So this is not how we typically do Kaplan-Meier curves, but we did a Kaplan-Meier and we said, okay, we're going to take everyone who made it to 4 centimeters. We're limiting our population to anyone who made it to at least 4. And then we're going to dichotomize you. We're going to say you have one of the 3 risk factors, and that's you are pregnant right now or peripartum, you have a high tortuosity index, or you've had a type B dissection without a root replacement. And we'll put you in, you're in the high risk category, or you're everybody else, you're in the low risk category, and we followed to see what happened. And if you look, the low risk category, not one person had a type A dissection until 5.7 centimeters. And immediately, all of our other dissections occurred in those patients, so much by 5 centimeters, 20% had a type A dissection. So we'd argue that these 3 risk factors are actionable. These are patients with Marfan, TGFBR1, and TGFBR2 that had dissection less than 5 centimeters. And the sensitivity of this was 100%, specificity 30%, positive predictive value 30%, and negative predictive value 100%, meaning that if you didn't have one of these, you could wait until 5 centimeters, even in TGFBR2 mutations. So this, as you saw earlier, when Bart presented a lot of the other tortuosity data, there's been about 6 other papers in arterial tortuosity showing that it's associated with dissection. This is a nice large one. It's a secondary analysis from the Dutch randomized controlled trial. And they looked at aortic tortuosity instead of vertebral artery tortuosity, but showed that increased aortic tortuosity was associated with higher aortic dissection rate, including type B aortic dissections. So what this tells us about arterial tortuosity, that it decreases during childhood. In addition to aortic size and gene, age, sex, index tortuosity, pregnancy, and primary type B dissection without root replacement are risk factors. Aortic tortuosity may increase with age, and it also appears to be associated with a dissection risk, aortic tortuosity, in comparison to vertebral artery tortuosity. And just have another minute, I'm just going to clip through a couple of these things, but just to show you this is, here, let me look at this. This is a large family, so can this help us with this familial variation or modifiers that we've talked about. This is a large family that I care for, and I was introduced to the family because there's 2 men in the family that had aortic dissection. But then we looked at everyone, and there's 2 women who have had no events. This woman's 60, she's 64 now, no events. We say, well, maybe it's a male-female thing. But then there's a young daughter who's very severe, severely affected. And what we did is we looked at the tortuosity and all of these family members and said, does that tell us the modification? We could have told this at a very young age. And in fact, it did. The 2 men that had dissection both had a VTI around 200, and everyone else was lower. This one person that was 110 is that 3-year-old who has not had an event, but she's only 3 years old. And we saw that whether we used vertebral artery tortuosity, aortic tortuosity, or height-adjusted vertebral artery tortuosity, there was a correlation. And so basically, again, looking that we should associate it with birth. And this is the last thing. Should we use this to predict events? This is a nice paper that just came out this year looking at multivariable nomograms. This group, this is a Chinese group, took all these things into effect. These were other factors they took into effect and made a complex modeling. This is really hard to use, to be honest. We're doing it on the computer for our pediatric population. But you can basically draw lines at each of their risk factors and add up the number of points of risk they'd have. But I'd argue that we need to go forward and do more complex modeling than just looking at the patient going, female, Marfan's 5, gut. And we need to sort of put these into more complex models with better data that we're all contributing to. And I think that's sort of it. This is just showing how we're doing our model, but to predict these, sort of to computer model these events so we can predict what would we do if we did surgery, what would we do if we had no surgery. So this patient would be a 3-year-old with severe root dilation. And putting in a model, surgery would actually have worse mortality. So basically, in summary, the impact of BAV may be different with different conditions. Vertebral artery tortuosity and aortic tortuosity are probably really important, and using modeling methods like microsimulation I think are where we need to go rather than just using gut going forward so we can get better evidence to treat these patients on a precision level. Thanks. Thank you, guys.
Any questions for Shaine?
When you did model the type B dissection, pregnancy, and tortuosity, did you have family history in there and that didn't come out positive? Or?
So the family history is, so it depends. If you just say family, it's hard to model family history because what does family history mean? Does that mean family history of a dissection? Family history of a dissection at a small diameter? Because if you have a family history of a dissection at 8 centimeters, that's protective. If you have a family history of a dissection at 3, and so the GenTAC cohort that wasn't well delineated, we have that in our patients, but I think we had 3 patients that had a family history of a dissection. So it really wasn't additive, and you'd have to say, I mean, I think the one that would matter was family history at a small diameter, and I think that was a single patient. It's just really unreliable, and a lot of our patients don't even have a family history. So then do you count that as negative or positive? You know? So no, we didn't put it in because it was too unreliable. But it's actually not. Great. Anything else? Great.
Good. Well, thank you very much.